I'm Susan Welch, and I'm very happy to welcome you tonight to what I know is going to be an interesting panel and audience discussion on Do No Harm, Medicine and Ethics on the Anniversary of the Nazi Doctors' Trial. This program is part of a public service media and research university project, which is a collaboration between our Science, Medicine, Technology, and Culture group, which we call SMTC, of the Rock Ethics Institute and the College of the Liberal Arts. And the other partner is WPSU TV-FM. The project combines a study group that brings together faculty, WPSU professionals, and community members to discuss the challenges and opportunities presented by the university public service media relationship. And it also includes these lobby talks, which goal is to advance public understanding of contemporary issues that relate to science, medicine, technology, and culture. Now, the motivation for the panel discussion tonight is the recognition that this year is the 60th anniversary of the beginning of the Nazi doctors' trial, obviously in 1946, right after World War II. The trial is renowned not only for prosecuting 23 leading German doctors and administrators for their participation in war crimes and crimes against humanity during World War II, but also for establishing the so-called Nuremberg Code, which deals with permissible medical experiments, a code which guides our ethical standards today for experimentation and informed consent on human subjects. The moderator of our panel is Greg Egan, sitting to the left there, an associate professor of history. Greg, I won't give a lengthy academic title, but I will say that he has a PhD in European history from the University of Chicago, and he came here to Penn State in 1999. He's published widely in German history, including his book, Making Security Social, Disability Insurance and the Birth of Social Entitlement State in Germany. Most recently, Greg has turned his attention to the role of psychology and its interaction with the state in the defining of criminal deviance. And to do this study, Professor Egan has looked at the role of the state in the Nazi period as well as in the post-war, more democratic Germany. Greg will introduce our other two participants tonight. And we won't have a real formal set of presentations, but rather some brief introductions and then opening up to audience discussion of this topic. So I'll turn it over to you, and thank you all again for coming.
Thank you. Well, thank you very much. We will, in fact, be opening this up for a broader discussion. But first, I wanted to make some introductory remarks, then talk with the two other panelists for a while, and then just see where things go. As Dean Welch indicated, the title for this is Do No Harm, with a question mark. Of course, this famous dictum, this injunction, comes from many centuries ago. We trace it back in Western history to the Hippocratic writings of the 5th century BCE, where there's a very famous line in one of the writings of the Hippocratic corpus, when one of the Hippocratic physicians, may have been Hippocrates himself, made it or put it down as one of the principal responsibilities of the physician to, quote, help or at least do no harm. Now, of course, this injunction seems to have been flagrantly violated and abused during the Third Reich. In January of 1933, Hitler and the Nazi Party come into power, and they are going to reign for another 12 years. And over those 12 years, under this authority and under this party, the German medical community is going to find itself engaged in a number of activities that, following the war, in some cases during the war, will be understood by many outside of Germany as constituting medical crimes and at the very least, medical atrocities. And there's really three that we talk about in this regard, three kinds of sets of medical atrocities, if you will. The first is a set of programs that were designed to sterilize large segments of the population, forcibly sterilize them. The category of people that were defined as now subject to this sterilization law, which is instituted within the first few months of the regime, were a group of people defined as hereditarily ill. This was a fairly broad category of individuals, and it entailed people who were understood to be suffering from bipolar disorder, schizophrenia, hereditary blindness, hereditary deafness, and the largest category of all was a category called feeble-mindedness, which somewhat equates to what we would define today as mental disability or mental retardation, though it was far more expansive than that. Under this program that the Nazis instituted in 1933, some 400,000 people are going to be forcibly sterilized by the time you get to 1945. 5,000 of these people, at least, will die in the process of the sterilization surgery. 90% of those are, in fact, women. In addition, as part of this sterilization project, some 30,000 eugenic abortions are going to be performed on individuals, on women. And then also of related interest, or a related part of this project, was also the forced castration of some 3,000 male homosexuals. That was also seen as part of the eugenic sterilization operation. Another set of medical atrocities revolved around a project that the Nazis defined as euthanasia. This was a project that began several years into the Nazi regime at the order of Adolf Hitler himself. This project targeted so-called individuals who suffered, or the way in the language of the Nazis was termed, people who had lives unworthy of life. Many of those people were the same categories of people who you found covered under the sterilization laws. But we're talking here about people who were deemed to be irreparably ill or deformed or abnormal in some way. And in 1939, a program called the T4 program was initiated by the state, by the Nazi regime. And what it did was authorize the killing of individuals who were found to have lives unworthy of life. The program began, by targeting children in hospitals and clinics. It then expanded to adults, and then was further expanded then to senior citizens as well. The program itself was ostensibly called off several years into it due to opposition from a variety of people and organizations, but particularly from parents and from family members who were finding out about this, but also protests from the Catholic Church. The program still continued on, however, even after it was ostensibly dismantled and disbanded. And in fact, it was later on, once war breaks out against Russia, the entire operation was militarized. And it then was expanded into Eastern Europe and into the Soviet Union, where now troops of the SS actually went into asylums, hospitals, nursing homes, and killed all the residents there as an expansion of this system. We now know that somewhere in the neighborhood of some 200,000 people were killed as part of this operation. Lastly, we know under the Nazis a series of medical experiments, coercive medical, human medical experiments were conducted. By 1945 or 1946, estimates are that this involved maybe somewhere in the neighborhood of some 80 separate experiments on groups and individuals defined as racial inferiors or expendables. This included some of, again, the categories we've seen already, the disabled, but it also included Jews, gypsies, prisoners of war, particularly from Eastern Europe, and children from these groups. And these were people who were experimented on within the confines of concentration camps, prisoner of war camps, and clinics and asylums of various kinds. The experiments were conducted by mainstream scholars, researchers, medical people in the field. Not all members of the experimental teams were members of the Nazi Party, and all the experiments, by and large, were seen as related to the war. They examined such things as the spread of infectious diseases, the treatment of war wounds, high altitude and cold water submersion, survival for the Air Force, the effects of drinking seawater, the effects of the injection of gasoline and cyanide, the testing of new methods in sterilization, which among other things included injecting caustic substances into the uterus or administering huge doses of radiation on men's testicles, and homosexual men were injected with huge doses of testosterone, ostensibly to try to see whether or not one could cure homosexuality that way. We still don't have exact numbers on the number of victims in these horrible experiments. At the time of the trial of the men and the one woman who were going to be put on trial for these crimes, the estimate was at 2,000, but recently the historian Paul Weinley, and I think quite rightly, has suggested that we rethink this, since so many of the killing operations in the Third Reich were in fact related to experimentation. That number should actually be much closer to tens of thousands, if not hundreds of thousands. It should be pointed out that in the killing operations and in the medical experiments, we are talking about a small minority of the medical community in Germany. There were roughly 60 to 70,000 physicians in Germany at this time. Most would not have participated in these. Most, however, would have been very much involved in the sterilization operation and all that that would have involved. They could not have escaped that. And it should also be kept in mind that we know that physicians were very, very loyal supporters of the regime. Of all the physicians, psychiatrists, and neurologists at this time in Nazi Germany, we know that some 50% of them were card-carrying members of the Nazi Party. In 1946, at the end of 1946, an American tribunal, military tribunal, set about to put on trial 23 physicians and researchers, as I said before, 22 men and 1 woman, for committing crimes against humanity and war crimes on the basis of primarily the human medical experiments. It was set down already in the first Nuremberg trial that no one could be tried for crimes that did not relate to the war. And therefore, no one was tried for anything they did before September 1st, 1939. What this meant, in effect, was that no one was tried for their participation in the sterilization program, and people were only tried for any of the killings in the euthanasia project if they directly, in some fashion, related to the war itself. So we know in the end that 16 people were going to be found guilty for their crimes, 7 of whom are going to be sentenced to death. What is, in fact, in many ways most memorable about this trial is not simply that judgment, but the fact that the judges, at the prompting of a group of American physicians, specifically Leo Alexander, John Thompson, and Andrew Ivy, the judges in the trial not only decided to pass judgment on the defendants in question, they also issued a 10-point directive on human experimentation. And that document, called the Nuremberg Code, was really the most far-reaching medical ethical document to date, and it laid down some important principles. Chief among them was the principle that, in fact, experiments could only be performed on human beings if the individual in question was allowed to give their expressed, informed, and unforced, uncoerced consent to be part of that experiment, that the human experiment be based on justifiable, reasonable scientific assumptions and humanitarian assumptions. And lastly, that the human subject had the right at any point in the experiment to call off the entire experiment if they feared for their safety or their lives. The document, as we may well end up talking about, left many things unclear. It was unclear who was to enforce these documents. Moreover, the document had, and in fact still to this day, has no legal status in American law or in German law. And the creed and the code itself also seem to place responsibility for the crimes less on the medical community, as we will talk about, than on the political regime itself, seeing really the problem of Nazi atrocities lying far more in the interference of politics over science than vice versa. So the questions, or many of the questions we're going to want to talk about tonight, are partly how did this happen and what happened, but it's also to talk and revisit this history in light of our state of knowledge today, where not just medicine is today, but ethics are today. Ask some large questions about what this teaches us about the ways in which we in the modern world have come to understand some of the most poignant questions. What is life? What is death? Who has the right to take it? What are the limits and parameters of medical experimentation? What does it mean to be able to give your informed consent to an experiment? These are all issues we will likely talk about today. So I'm joined today, I'm happy to say, first of all, by Janet Lyon, who is Associate Professor of English and Women's Studies, as well as being the co-director of the Disability Studies program. And then also by Susan Reverby, Professor of Women's Study at Wellesley College. Thank you very much for being here. All right, well, I guess I'd like to start by posing a question of you, Janet, and see where this takes us. And I guess the first question is the question I guess I often get from my students when I'm talking about these things, and that is, in essence, how did this come to be? How did it come to be that researchers, scientists, medical people would come to find these kinds of not just experiments, but policies reasonable? And specifically, how is it that the disabled, of all people, come to be blamed in some way for the ills of German society, and in fact, Western society in general?
It's important to keep in mind that the murdering of disabled people during the Nazi regime had precedence in this country, in fact. In the United States, the eugenics movement got started in around the first decade of the century, but it grew easily here because of the way that we, as a nation, had come to think of, from the very beginning, had come to think of citizens and citizenship as, and this is straight out of the liberal model of political philosophy, as that which is accorded to people who are competent and independent. And what rapidly grew out of that model, competence meaning you are mentally competent to enter into contracts, to write wills, and you have enough self-awareness to participate as a rational subject in government. And in return for that, you will acquire the rights of the citizen, protection and rights. So what happened pretty quickly, and particularly in the 19th century, was what people call a double tracking of citizenship rights, so that the model of competence and independence produces its shadow model of incompetence and dependence. And it's easy enough to categorize what were called the feeble-minded as being on that double track of citizenship. That is to say, they were not sufficiently competent or independent to be granted the rights of citizenship, which means that they would become guardians of the state, guardians of their families, not guardians, guardianees.
Dependents.
Right, dependents, thank you, in a sort of somewhat paternalistic system. And that was an uncontroversial thing. No one ever discussed the possibility, historically. All of the early state constitutions had written into them the understanding that people who were insane or feeble-minded would not be accorded the rights of citizens. Uncontroversial, simply a matter of fact. So that when the eugenics movement began to grow legs, as they say, in the United States, after Francis Galton first coins the term in England in the late 19th century and begins to think that it's possible to breed out bad stock and produce a sort of pinnacle race out of breeding in good stock or simply getting rid of anything like a contaminant in the bloodline. And Galton was not really a murderous eugenicist at all. He was sort of playing around with the idea of plants and animals. And then, oh gee, what if only well-bred people married each other? But it took people who were in the medical field to sort of run with that. And for reasons that I think have a lot to do with our own history of citizenship, it was extremely amenable to a whole group of eugenicists who had begun to form here. The first eugenics office, Eugenics Record Office, I believe, was formed in 1910 here, where statisticians, Galton was a statistician, began to sort of look through the population for forms of deviance from some norm. And typically the sign of the feeble-minded began to expand to include those who deviated from something like an idealized norm. The point being that it wasn't just sort of some fad that took off, but there was some very fertile ground for eugenics here. And in fact, I just recently read this, that the ex-president of Harvard, Charles Norton, at the turn of the century called for, this was headline news, called for, I'm going to get his phrasing exactly right, the painless destruction of insane and deficient minds. This was considered to be an extremely rational use of science in the progressive age.
It sounds like what you're saying is that the idea was that if you're talking about the feeble-minded, as they were called, that as dependents, the problem with them from this point of view of citizenship was they simply didn't contribute anything.
One of the things that the eugenicists introduced into the mix, and I think this is important, is that they were previous to the sort of eugenically ramped up rhetoric of national health and purity. The so-called feeble-minded or mentally deficient were typically viewed not as a category per se, at least not in the courts. They were not viewed categorically. For example, feeble-minded people could marry each other so long as they knew they were entering into a contract. There would be no state interference for that. That was one of the first things the eugenicists went after. And moreover, the so-called feeble-minded individual could exhibit certain skills which would suit him or her to, work in the community, to some form of employment, to something. In other words, a skill factor, there was still some level in which there was not some wholesale categorical dehumanization of type, but rather individuals were still assessed, for the most part. One of the things the eugenicists took great pains to do was to suggest that feeble-mindedness was an overarching category that trumped everything. So that if you were feeble-minded, that would be the defining thing for you. It didn't matter if you had any apparent skills, because those skills were contaminated by this pervasive feeble-mindedness that defined this category of people. So no marriage, absolutely no procreation, and increasingly no hope of living in the community. Increasingly a sense that feeble-mindedness had to be segregated from the population at large as a matter of urgent national health, because otherwise they would procreate and contaminate the bloodline and we'd all be lost. And this sense of national emergency really underlies a lot of the eugenicist rhetoric at the time. The most vulnerable, the least aggressive sector of the population was targeted wholesale. The term feeble-minded became the foundational term for eugenics. They loved the term because what they discovered was it could be infinitely expanded to include boisterous anarchist immigrants, to include women who would want to do something as unnatural as vote, to include, in other words, feeble-mindedness was this infinitely malleable category which the eugenicists were very drawn to. And moreover, they could establish the category of feeble-mindedness, and then there was all sorts of proliferation of terms around it. So you could have your morons, your idiots, your imbeciles, your high-functioning morons. All of these were feeble-minded. All of them disqualified you as a citizen. All of those attributes made you no longer a bearer of the rights of citizenship. And increasingly, feeble-mindedness was associated with deviance, and therefore it was criminalized. So this also made it much more palatable. The criminals are incarcerated, the feeble-minded are also incarcerated.
Right. So there's these political, economic issues that one also has to include.
Right.
For Susan, I guess I wanted to start out by asking another question that comes up a lot, and actually came up in the trial of these doctors. And many of these German physicians tried to defend themselves by saying, well, you know what, we didn't do anything that didn't go on in the United States and hasn't been going on in the United States. Right. And I guess the question one would want to ask is, were they right?
What the Germans basically said is, you've been doing all these experiments in prisons, in homes for the feeble-minded, in insane asylums, and there was evidence for all of this, and they used that as the defense, actually. So it made, particularly Andrew Ivy, one of the physicians who worked on the trial, quite nervous. And they said, well, was there a code in the United States? And so one of the things that's really interesting is we've used the term do no harm here for the title, which comes out of the Hippocratic Oath, which speaks actually to the job of the physician, but says nothing about experimentation. It's all about what you do one-on-one, but doesn't say anything about experiments. So you could say, I'm doing no harm, and I could still experiment for the nature of science. And so Ivy gets very nervous that there's nothing to fall back on, and he immediately helps convene a committee, actually, of the American Medical Association, a committee of actually one, consisting of Ivy, who writes a code, which he then comes back and presents to the tribunal in Nuremberg to say that the United States, of course, has a code that opposes this. So it's Ivy and Alexander and other people who help write the end of the Nuremberg Code. And then the question is, we have this code, and as Greg has said, what does it do? It's not like it's a law that's enforceable. It's kind of a statement of principles. And one of the things that makes it really hard to enforce it in the United States is it was the Nazis, and it's right after the war. So if you think about it, if you think that doing harm in an experiment means being a Nazi, taking Jews and feeble-minded people and infecting them with things, and dropping people from high altitudes and feeding them salt water, and you're not doing that, you're not violating the Nuremberg Code. And so it became one of the problems, I think, with using actually the code as the touchstone, is that it feels like something good Americans don't do. Like, we don't torture either, in case you haven't noticed. So it's not unlike that. If you think that only really bad people do this, then it's very hard to think about how it might affect you. And so one of the problems that we face, I think, in this country is trying to think about what would it look like here? What do we do? And so one of the ways it looks like here is, we know, of course, that well into the 70s, 75% of all the drug studies, for example, are done in prisons. There's a famous quote, actually, from a gentleman who did work in one of the prisons in Pennsylvania. I'm sorry, I'm from out of state, and I can't remember the time, which prison it was. But he was a dermatologist. It was Holmesburg Prison in Philadelphia, and he looked out, and he saw all these men, and he said, acres of skin.
Yes.
Because it meant he could do all this wonderful. Now, you could argue, as a physician, that these are people in prison, that they owe a debt to society, and one of the ways they should pay it off is to be available as human guinea pigs. And so we have, as a country, done things like that, or we have looked at children who were, one of the most famous and horrendous cases in American history took place at a place called Willowbrook on Staten Island in New York, in which children who were supposedly expected, who were mentally retarded, and were put there by the state primarily because their families could no longer care for them. And in the 60s, there were physicians who decided to look at what would happen around research on hepatitis. And since it was assumed that everybody in the institution would get hepatitis eventually, they gave these children hepatitis in order to do the testing. The study that I work on in particular is something called the Tuskegee syphilis study, and this is the longest running non-therapeutic, that is, doesn't do any therapy for someone, experiment in American history in which 399 African American men in and around Tuskegee, Alabama, in the south central part of the state, and 201 controls who had latent syphilis were told by the United States Public Health Service in 1932 that they were being treated for something called bad blood, which was kind of a generic term for syphilis, but also could have meant anemia and diabetes and hypertension. And the United States Public Health Service gave them aspirins and tonics and back rubs, and even did diagnostic spinal taps because they were looking for neurosyphilis in the spinal column. And the men thought they were in, like a lot of people who go into clinical trials, the men thought they were being treated. And they were told by the Public Health Service this was treatment for their bad blood. But in fact, they were followed. And they were followed for 40 years. It has a kind of, I think it's the 40 years has a kind of biblical quality to it. It makes you feel like it's like Moses wandering in the desert. And they were watched. And they died. I mean, numbers of them died. We'll never know exactly how many of them died, but it went on for 40 years. And it, unlike some of the experiments in Nazi Germany, this wasn't being done like in a concentration camp, although some of you may think that Alabama is close to that. But in fact, there were 13 reports of the study published in respectable medical journals, including the Journal of the American Medical Association. People knew about this study, but the very language of the reports, which speaks to some of the things Janet's saying, in which the men were actually referred to as volunteers. And in a time in which we had no real codes about what you could and couldn't do, there was no protocol for the study. Those of you who do research know any research study now has to have you have to write the thing up, it has to pass muster with a board. There were no such things. You just basically called the smart other guys in the field and said, hi, this is what I'm planning to do here, what do you think? And it went on for 40 years until 1972. And one of the things that's really interesting that brings us back to the Nuremberg Code is that when there was this huge uproar, as you can well imagine, over the study in 1972, there was an interview with one of the physicians who had run the study, and in the interview with him, the question was raised, well, didn't the Nuremberg Code after 1946 give you guys any pause that these men thought they were being treated, that you never got any kind of informed consent? And the physician looked at the person asking this question and said, we weren't Nazis. And so I think what the point here is that, and then one of the things that happens, I think, in the United States is that in some ways people refer to Tuskegee as America's Nuremberg. And the problem becomes if you're a researcher here and you think, I'm not a racist, I'm not in Alabama in 1932, or even for some of my students, 1972 might as well be 1872, right? So that's like before they were born. So I don't do things like that, and it doesn't have any resonance. And I think one of the things we have to struggle with as a nation is to think about what kinds of protectionism do we want that allows science to go forward. I'm a doctor's kid. I'm probably alive because of antibiotics. I'm very grateful people do research. I wouldn't want to stop 99 and 44 100% of what goes on. But I also think we have to really worry about what kind of consent we get from people, how people are coerced, and what happens on the day-to-day basis that isn't maybe as horrific as what happened in Tuskegee or in Nuremberg, the Nuremberg reflected, but in fact happens in the little ways, in the day-to-day kinds of things that happen. And I'll just give you one small personal example of kind of what I mean about this kind of problem. My son had something called benign Rolandic seizure disorder. He had a grand mal seizure when he was about 8 or 9. So we're at Children's Hospital to find out whether or not he has a brain tumor. You can imagine how anxious I am as we're going in for the MRI. And as we walk in, the person about to do the MRI, who's going to tell me afterward whether or not my child has a tumor, says, "We're doing a research study, and would you mind if we leave him in there for an extra 20 minutes, right?" And I'm thinking, I'm a historian of the Tuskegee syphilis study, right? Poor African-American men, right? I'm a nice white middle-class Jewish girl. This is my kid. This is Boston. I should say yes so that we equalize the, and I'm thinking, I said, well, how long, you know, and it was about the same amount of time I thought we were going to be in this. So I said, sure, right? And then after, you know, and it was fine, and he didn't have a brain tumor, he's fine. But afterward, I thought about this, and I thought, that was really coercive in this very minor way. That is, I'm a mom, my kids, this person doing the study, what if I had said no? Somewhere, now I think I said yes because I thought you should equalize research things, but I think on some level also, as a mom, when I could access that part of my anxiety about this, that I, as a mom, said, oh my God, what if I say no to these people, and will they tell me the answer? And so I thought, well, if I'm cooperative, I'll find out whether my kid's dying or not. And I think that we should worry about those really small kinds of cases as much as the really big, huge ones.
I thought instead of us yakking some more, we'd open it up for comments, questions, suggestions, whatever. So is there anybody? Yeah.
Another place where they were doing the same kind of study, following people, just watching the disease progress rather than intervening. And that was in a place I've done research on in Britain, Strangeways Research Laboratory, which was set up as a research laboratory to experiment or to watch the course of malaria. So they brought in a lot of people with malaria, and they just watched them. And at a certain point, they switched over to working with tissue culture instead of with the people, because then they could experiment on the level of the tissues rather than on watching the people just have the course of the disease. But it strikes me now that that kind of moving from the whole patient to working on tissues, may not actually prevent kinds of really drastically problematic experimentation now. You can't just make the switch. And I wondered if you guys had any thought about this, experiments that are at the level of tissue, parts of the body, rather than the whole person.
There's beginning to be some conversation about, especially with the new work on stem cells, is who owns the tissue culture. I mean, one of the very first stem lines, actually, that gets, cell lines that gets created is from a woman named Henrietta Lacks, who was a patient at Johns Hopkins, of course, and who died of cancer, and they used her cell line. They were called HeLa cells for her name, Henrietta Lacks, who was an African-American woman, and her cells then developed one of the very first cell lines, and some of the early research on polio vaccine actually was done on the HeLa cells. So one of the questions we want to ask is, does the Lacks family own her cell line as it goes down? And what do we think about that as a culture? Do we think that people should have rights? If somebody starts to make a lot of money because they develop a vaccine on it, should the family whose cell it was originally get that money? But I think what your question raises is, again, I think the question I'm trying to ask here, which is, what do we as a society want as control here? Because we want science to happen. As I said, I think we have to think about how do we help? Do we need code? I mean, I want you to think about this. Do we need more laws? Do you just want to sue everybody, if they make a mistake, which is basically how we manage it in this country? Or do we want to think about both the education that has to happen for physicians, but also how we in the public who aren't doctors and scientists think about this ourselves? What do we want as a country? to happen? What kind of conversation do we want to have about this?
Within a very litigious society, the IRBs, or the Human Subjects Protection Boards, have sort of a dual role. That is to protect the institution,
Right.
and to protect the public.
Right.
And I think I do a lot of work with children, and so informed consent, which is
Very
informing them of their rights in a legalese language which protects the institution,
Right.
is not a particularly useful way of informing young people. And I think that's sort of broadly true for the public at large. And we don't do much to educate the public about why you do science, why it might be in the public interest, and what their rights are altogether. So,
Right.
I don't know what thoughts you have on how institutions could do a better job of educating the public and informing them and doing better science in the end.
I think, frankly, go be a high school science teacher. I honest to God, I think they're the best people on the planet. I do, because I think part of the problem is that people really don't have any conception about how science does it work, and concepts of probability and what clinical judgment is, and all the kinds of questions that medical researchers manage with, and so people don't understand. So they'll often they can't afford to understand. For example, and many people with HIV/AIDS if they can get themselves into clinical trials, often the only way they can afford the drugs. So people get into a clinical trial and think, okay, this is going to be great because I'm going to get the cutting edge drug, without knowing, first of all, which arm of the study they're in, or even understanding that a clinical trial might have 2 arms. There's just the scientific illiteracy of our population is so enormous, and it's really hard to think, I think, from the scientist's point of view, is we're supposed to write this material at a level of, I think, is it 7th grade, I think, literacy level, in informed consent forms. But when you're in, like the example I gave of, the anxiety of your child, or you have no money and you're in what Larry Langer called, during the Holocaust, people's choiceless choice situation, how do you make an informed decision? How do we make sure that research, the director of NIH had a great line about this in the 60s. He said the difference of doing research on people versus research with people. So how do we set things up so we do research with people?
It's, I can't help but think of it historically as an historian. And in part, my first reaction is to say, in many ways, we are far more informed today than, say, people were 100 or 150 years ago, particularly because we have an awareness, and I guess when I'm using the term we, I think particularly in, industrial capitalist societies with a long history of that, where you have had develop over time, and particularly since, say, the 1950s, a sense of a consumer ethos and consumer movements and consumer rights movements. I think one of the ways to, in a sense, try to subvert that or to balance that off is with, in fact, that kind of consumerist consciousness. What am I swallowing? What am I buying into? What are those services? And I think that is actually can be largely effective. I think, on the other hand, historically speaking, when I start thinking about it, I'm not sure things have changed all that much. The very ubiquitous Roy Porter, a very famous historian of medicine, had made some very interesting points when he studied, I think it was 18th century England, and he said, what we find there are patients were not these sort of passive people who sat by and let doctors do whatever. What they did is they complained, they demanded treatments, they asked, what are you going to do next for me? If they didn't like it, they went to another physician, they did all that stuff. They were very, very active. But the commonality between, it strikes me, early modern and we modern folks is largely still the art, as it was then, and the science now is in a black box. In some sense, in the end, it's like my mechanic is for me. I'm not sure what goes in there. All I want to know is, after I pay my money, does the car move forward when I hit the accelerator? Do the brakes work? And there is that sense I get, I think, that is a kind of a continuity over time, that the patient, that the consumer, by and large, often is satisfied with something called a result and is not terribly curious.
But I would say that things have actually, I used to be an RN, and I trained at Yale New Haven Hospital, and I worked when I used to put myself through college and graduate school working in coronary intensive care units. And I can remember very well, first of all, at Yale New Haven, this extremely cavalier attitude towards, literally, this just fell off the truck. Let's try it on you. And there were no mediating bodies. There were no medical ethic bodies of people, such as what you just described, who could be called in for that kind of a thing. I mean, the nurses were more or less in charge of being the firewall between what we used to call the cowboy doctors and the patients. And this was actually also fairly common. I can remember working night shifts and having cowboy docs coming in and saying, I got this new thing called amiodarone. Got any patients I can try it on? And it was really that uncharted, it was just sort of. So the point is that these boards that hospitals have sort of put together both to protect themselves and their patients, are a start, particularly if they have gifted people on them, rather than just kind of drones or bureaucrats, which sometimes is what happens as well.
What Janet's raising, though, differentiates, which really actually comes out of both Nuremberg and then the declaration at Helsinki in '64, which is the differentiation between what we might think of as therapy. That is, hi, I'm Dr. Cowboy, and I'm about to try this new thing that just arrived from the drug company or the device company, and I'm going to see if it works, and that kind of, and what we might think of as non-therapeutic experimentation, where you have. So if you're the patient, you might imagine if you said, listen, I told this story last night, but when I gave a lecture here, but I'll tell it again. My dad did early research on penicillin and its use in bacterial infections in the heart. And so I said to him, and this is in 1946, I said, so Dad, what kind of informed consent did you do? And he said, I told the patient, they didn't try this new drug, they'd die. Now, he wasn't wrong. And so I think about that as kind of, he wasn't wrong. Bacterial endocarditis was a death.
Pretty much,
You died. Without penicillin, you died.
Very painfully, too.
Yes, it's terrible. So, he felt perfectly happy saying that to his patients, and that was his version of informed consent. And often with therapeutic things, I once had a conversation about a new drug I was taking with my physician, and he said, I don't let patients take anything that has been out for less than a year. And I said, listen, I have this real problem. I'm willing, frankly, to take anything. I know what the risk is. I don't care. Just write the script. So there's the therapeutic experiment that happens, frankly, every time you see your doctor on some level, because until we have absolutely, for you, individualized medicine, everything is an experiment. I once had hand surgery and it didn't work. And the doc said, it works on everybody else. I do the same thing on everybody. I said, I'm not everybody. So I was his experiment, it didn't work. He failed. So there's that kind of therapeutic experiment. And then there is the non-therapeutic, when we're testing a new drug, when you're a healthy volunteer. And then the question becomes, under what conditions? And that's a lot of what I think the IRBs also look at, which is what happens in that situation when there's no reason for you to assume that you're going to benefit, but you, out of the goodness of your heart, or, hi, you're a college student, you're giving the blood, and you're joining this study because you need the bucks to help pay your tuition. We know people volunteer all the time for that kind of stuff. And so we have to think about both kinds, regulation of both kinds of things, the day-to-day stuff that happens and the non-therapeutic.
But also the patient populations who get targeted.
Yes.
In other words, you're talking about informed consent with children. I'm going to go back to the most vulnerable people. Informed consent with intellectual disabilities is a dicey game.
Right.
You revert to the model of sort of guardianship and paternalism, and that may be adequate, but it may not be adequate because, once again, there is no such thing as all of those people. It's lots and lots of individuals. So I always worry when I'm aware of drug trials. There are a lot going on right now because of the Alzheimer's research boom, which is tied also to Down syndrome. So there's looking at two very vulnerable populations: the elderly, who are usually by the time they're doing trials, there's significant disease, and people with Down syndrome. And in both cases, you're no longer in that liberal philosophical model of competence and independence. You're just not there. And maybe that means we need to revise that model of who counts as agents in their own lives, you know?
University of Wisconsin history professor Alfred McCoy has recently published a book describing his decades of research into CIA intelligence or information gathering techniques. In this book, he describes the military, the Pentagon, and the CIA setting up the Guantanamo Bay prison as a research facility that developed the techniques of pain infliction, uncomfortable positions for long periods of time, and sensory deprivation in combination with playing on cultural sensitivities to extract information from prisoners. And he describes, and it's also fairly well known, and in fact the American Medical Association has spoken out against this, that U.S. military physicians and psychologists are involved in these experiments and these interrogations. And I'd like to ask the panel to please comment on the fact that these experiments are going on and the fact that psychologists and U.S. physicians are participating in them.
Well, I think it raises the same kind of question that the Nazi, in some ways the Nazi involvement does too, in the what do you do in the name of national security? And we know, for example, from the Radiation Commission reports that came out about a decade ago, there were almost 4,000 radiation studies done between about 1946 and 1974 across this country. Not all of them were horrific, but a number of them, you know, did these kinds of things, and doctors participated in them. And I think I mean, I don't know this gentleman's book, but what it raises, of course, is, you know, physicians, when they do this, are not just physicians, they're also members of they're citizens of a state, and they absorb the rationale of that state. And so you could imagine in any situation that you were doing this for the greater, utilitarian view of the greater good of the state, and you could imagine that it was okay. And so I think one of the questions the AMA is trying to do is the same thing with the two anesthesiologists in California. This has just been happening the last 2 days. These two anesthesiologists who refused to participate in the essentially state murder of this man who's on death row. The question is, at what point does your conscience as a physician, should it kick in or not? Or can you say in this situation, yes, I have this conscience as a physician, but in fact, I am serving the state in this way that's important, and I think that this is okay to do this. And I think that's certainly the cases he's raising are people who made that decision. And sometimes people do stop doing that at great personal risk. I actually worked in the 70s with a physician whose name people probably won't know now, named Howard Levy. And Howard was a dermatologist who was in the U.S. Army, and he was asked to train Green Berets during the Vietnam War to essentially inflict, how to harm people, basically, in Vietnam. And he refused to do it. And Howard was court-martialed. I mean, he was sent to Leavenworth. He was in prison for several years for basically disobeying orders and refusing to do the treatment. So there have been physicians of conscience historically in this country who have refused to do that. But there are going to be people that go along with this because they think it's the right thing to do.
What I see raised by these issues are really two. One is this question of the individual physician, psychologist, psychiatrist as physician, psychologist, and psychiatrist, and the other is as a citizen. And I think what you often get, the arguments that are made on behalf of this participation to defend it is really twofold. One is a medical argument, which is, especially for the physicians, we are there to oversee interrogations, to make sure they don't get out of hand, to make sure that, in fact, the person is going to be safe. And the person is going to come out of this all right. And the argument that's often made were the physicians to, as a community, just simply remove themselves from that environment, then it would be left open to people who have no medical training at all. I think there are problems with that argument. The other argument is that these are people who are participating in these ventures as citizens, as patriotic-minded individuals who want to serve their country. And in that regard, they're really not behaving as psychologists or psychiatrists or therapists. They are military personnel or they're civilian personnel helping the military. And that is an argument that one often saw, I think, during the Third Reich, but not just simply during the Third Reich. You see this constantly at times of war. I don't know if we'll have time enough to talk about this, but one of, I think, the things that often gets neglected in understanding this milieu, this environment, this climate in Nazi Germany is the specter of war. War is all around this. Even before World War II breaks out in 1939, the specter of the First World War is standing there, really influencing and giving and really feeding these eugenic ideas.
The Black Stork movie is 1915.
Yeah. So I think that you raise an issue that I think is a very large question about what exactly is and should be the relationship of the healing professions in times of warfare. Where does the physician's obligations to do no harm start to become, start in some fashion to have to be rethought within the confines of warfares where other kinds of behavior and conduct seem to be legitimated or mandated? So I think it's an interesting set of questions you raise for us. We'll get a microphone over here to you. Yeah.
All right, how about, let's go to a broader subject, evaluations of pharmaceuticals where they use, 50% of the people will be on placebos.
Right.
I was qualified for one, but I was told that the program would be, I think, 3 or 5 years. And I didn't want to go through 5 years of possibly not being treated for this condition.
Right. They just stopped that breast cancer study. I forget what the drug was, but the drug was so effective. They got such immediate results in about 4 months that they stopped the study and put everybody on it. They took out the placebos from the study.
Well, I suppose
just,
the other way,
and that the other way,
getting told about it.
Right.
there has been that as well for a recent,
Right.
for a recent blood pressure drug. That exactly is what happened.
I mean, part of it is that what's called the gold standard in research has to be the drug against placebo. So sometimes the argument is made that the better way to do it would be the older drugs versus the new drug. And so some trials are like that. At least in your case, it sounds like that it was explained to you. I mean, I think that's the best we can hope for, that it explained to you what the risks are, and then you can make an informed decision about whether or not you want to participate in this. But on the other hand,
There was a small financial incentive.
yeah, there usually is.
But it's a long time.
But that's a long time, and you can only hope that if the results, I mean, we do have rules that say if the results, there's usually some kind of statistics board that oversees the drug trials, and so if it looks like the results are really completely out of whack, they often stop the trials early. The problem sometimes is that that's terrific. I mean, I just sat in on the FDA had hearings on this new drug called Bidil, which is a whole other story, but they stopped that trial early because they thought the results were so terrific, but it leads, for those of you who are statisticians know, to some really funny statistics because it shortens the time that the trial was actually done, so we're not sure about the long-term consequences and the numbers. You have lousy stats to do the work with it. But in your case, sir, at least you had a chance to make a decision, which is, I think, a really good thing. And maybe other people would say, sure, for the good of science, I'm willing to do that, and hope that if anything really shows up, you'll be the first in line. So one of the things we hope will happen in drug trials is that people who really need the drug will get it. One of the problems we're facing is increasing many of the drug trials are being done overseas. Right. And so one of the things we're facing at the moment is real discussions internationally about what kind of protection are you going to give to people in Nigeria or in some province in China where Merck is, and then you've seen the Constant Gardner movie, about this kind of thing in Kenya. What kind of protection are we going to give to people? And what happens in those kind of trials is just, I think, a lot what happened in Tuskegee, which is when the Tuskegee Institute people agreed to the study, there was no health care. And so it was a way to get at least a modicum of some form of at least aspirins and tonics to people. And so lots of times in the third world today, I think people say yes to these kinds of trials because there's not much choice.
And the financial incentive
Are
is an
enormous.
important thing to talk about
Yeah.
because, you know, who sells plasma? People who need money. Who signs up for drug trials? Volunteers who need money. I personally was in 6 when I was in nursing school. You know, I mean, once again, it's a vulnerable population because of the attraction of the financial.
The people who are motivated. I mean, what's interesting, though, in what is, historically speaking, is right since about the 1980s, really, we've had this thing that is kind of different, which is particularly among cancer patients and AIDS patients, right? This desire on the part of people in that community to demand experimental drugs, to in fact, and this raises a whole new set of questions. It's hard not to say informed consent is going on there, but is it really quite where we want to go, where people may be, in fact, out of desperation, demanding to be part of experiments when it really, the time is not right, or they can't really truly understand the consequences?
Well, it raises this really interesting problem of without access to resources, where do you go? And so part of the reason ACT UP and all the AIDS groups did this was that a lot of the early research was being done actually in the communities, and people were setting up trials by themselves in places like San Francisco, and so there was a real pressure to what was called fast track a number of drugs through the Food and Drug Administration. And I, you know, as someone who came of age politically during the 60s and 70s, when all the issues were the way women were used in the drug, you know, in the pill trials and in IUDs, and I kept thinking, you want to hurry into this? So I've had a really hard time watching it. But that balance between, on the one hand, can we get the newest stuff out as fast as possible to people, and how the FDA makes those kinds of decisions, it's really tough. It actually is really tough. I sat as the in the mid-90s, I sat as the consumer representative on the Obstetrics and Gynecology Devices Advisory Panel for the FDA, and I got to see it in real time, and it was really, really hard. I mean, I'm here to say that these are not simple decisions that often, have to get made, because you want, as an academic and a scientist type, would sit there and go, well, we need 20 more years of data and blah, blah, and then you'd have patients who have been saved by, or thought they'd been saved by this standing up and testifying and saying, I'm alive because of this drug or device, please make it available to everybody. And you're sitting there going, well, I'm sorry, but the P equals 0.05 isn't there yet, and the cell is too small, and we don't have the data. And everybody's going, I want this drug now, going, now.
Yeah, very difficult when you've got a human being standing.
Yeah, it's great to write it as a historian.
Get somebody in the back.
If someone has signed on to or joined a long-term, a number of years study, and during that study period, results come out from another study on the same medicine and sort of directed along the same paths, how should that person feel about wanting to withdraw themselves from the study that they signed up for, not knowing that they're on either the placebo or the real drug, and then go ahead and start getting the real drug for sure?
I think this is one of those cases where hopefully the people who are running the trial that you're part of would look at the other results and try to figure out whether or not it's comparable or not, and it's fair enough for you to say, look, here's these results, I want you to unblind my case here, and I want to know which arm of this I'm in, or I'm withdrawing, and I don't know whether you could try and negotiate that kind of change with it. I mean, part of the problem is that people's reputations are made on these studies, promotions, your deals with the drug companies. I mean, there's all the kinds of incentives that push people to keep people in their studies and make them keep going. But my guess would be to have a conversation about this with the people who run it. And then, this isn't Nazi Germany. You do have the right to withdraw yourself if you're uncertain and to talk to a physician about whether or not the new drug makes sense for you. I mean, it seems to me you're right as a citizen here and as a human being.
So it could be good to have a discussion with people.
Sure. Sure, why not? Absolutely not.
Get somebody way over there. Oh, we got one person over here, I don't think, who's had a chance to.
Yes, I had a concern about so many of the drug ads and every form of media. And then when you're sitting in the doctor's office and you see the rep come in with all the toys and the gimmicks,
Yeah.
every clipboard has got a drug on it, every pen, the Kleenex boxes, and you're sitting there and you don't have prescription drug coverage, and you go up to the manager and say, I want one of those pens, at least I can have that. And they really create a form of demand since that was legally allowed.
That's right.
And so that was a concern I have in my own experience.
Right. My
Thank you.
favorite is the ads that say, that have somebody dancing in a field, you know, and then it says, ask your doctor if you should be on blop. And I'm thinking, what for what? You know,
don't even tell you.
They don't even tell you, you know, what it is. And I think, I mean, one of the issues it really raises, I mean, frankly, when I got on the FDA panel, I was completely shocked that, in fact, I was so naive, that all of these trials were paid for by the drug and device companies. I mean, I had no idea that the feds weren't involved in a lot of this research. I really didn't. And I think that that's a real interesting problem about how a society pays for the research and development. And I think people should have the right to make a reasonable profit, but it's an unreasonable profit that I have troubles with, and what it means to bring things to the FDA. But you know, I do worry about the ads and the push that's happened and the extent to which docs are and we know there's studies on this, docs are learning mostly about what's new out there from the drug reps and the information that they bring. And it's I think it's a real problem.
Alongside what we've termed the medical crimes that took place in Nazi Germany, there were also very significant developments that took place in the coordination of the medical community alongside the government. For example, in things like the eradication of smoking or cancer prevention through lifestyle changes and dietary changes. And what I'm wondering, if we think about kind of these two things alongside one another, are the atrocities that we've been discussing sort of an inherent risk in the involvement of the state in health promotion? And what I'm thinking about this is in the context of kind of the normalization of lifestyles within our contemporary culture and kind of campaigns to eradicate obesity or to institute taxes on things like snack foods. And so I'm just wondering if you might have any comments on these two things in relation to one another.
You are certainly correct to talk about the idea that it's important when you look at this historically, and it's one of the things that I think, in fact, makes one of the things that makes the Nazi case quite different from some of these other things we've been talking about, is because of the preeminence and prominent status of the state, of the government apparatus in all of this in Nazi Germany. But at the same time, I think it's important not to overestimate that importance. This isn't the venue, really, to get into a long sort of discourse about the structure of the Nazi state and Nazi society. But in a nutshell, I think it's fair to say that one of the things we know about the way that system operated is it was not like one typically sees on that otherwise wonderful channel called the History Channel, in terms of a set or a group of individuals in political office who are sort of dictating orders to the rest of the community and specifically to certain kinds of professionals. Rather, we now know, after many years of scouring the archives and looking at the records, that the system itself was very, very fluid and that it worked as much bottom-up as top-down. That we have consumers demanding certain things. I think it's one of the really frightening stories, for instance, about the euthanasia campaign, that it begins because an individual, a man, a father, approached Hitler himself wrote a letter to Hitler saying his son was just born with a deformity and he would like to have his doctor be able to end his life. We have plenty of evidence that there is something of this sentiment within the population in general. And moreover, we know that the doctors are bringing something to the policymakers and the political authorities and saying, you know, let us do what we do best. We don't need interference. We will do exactly the kinds of things you will be proud of. So in fact, in many ways, the story I don't think is one that is imaginable without a very powerful state involved in all of this. That said, it is also not explainable, I think, by simply invoking the idea that we have really Big Brother watching. And that, in many ways, is what makes, from my mind, my thinking, so frightening about the Nazi example, and why I don't think it's just about them then. It's very much a story that we need to think about for today as well. I hope that addresses what you were talking about, but I don't know if others.
And I would just say that in the United States as well, just as there were parents writing, it wasn't just one either, writing to government in the 20s even. There was a petition of 160 parents wishing to euthanize their children, or to at least make sure that they were sterilized, and then perhaps if there was euthanasia.
I think we have another. Yeah.
I might be going off topic a little bit, but I'm currently enrolled in a class where we discuss issues in science. And today we had a debate about golden rice, where beta-carotene is used to genetically modify the strain of rice in order to fight against vitamin A deficiency within developing nations. And I was just wondering how you feel about something like that in relation to what we've been discussing tonight.
On whether the research should be done at all or should be provided?
In terms of using food, genetically modified foods as a treatment source for others.
And who's doing the distribution, or who's overseeing this? Is this a government-sponsored thing?
Well, we did like a mock type of debate in class today, and it was the main thing would be the World Health Organization.
The WHO is sponsoring this. Is that?
I'm not really sure about.
This may have been a hypothetical.
Was
a hypothetical?
Yeah, basically, because we've been talking a lot about genetically modified stuff, and
Okay, got it. Okay. So hypothetically, if this were introduced as a way of, addressing or even eradicating vitamin A deficiency, the question is is it a poison pill? And who has the right to make a decision to distribute a poison pill, even though, it may be, may not be. It might be a panacea, who knows? Yeah, it's an excellent question, and my guess is that if it's an HMO or, WHO or an IMF or an HMO, money's going to be the bottom line. That is to say, what's the payoff going to be? So, with the HMO as well. I don't know.
It really isn't something I've, honestly, to tell you, I haven't thought about. I can think about it right now, but I haven't taken a position on it. But I think the question it raises, particularly in other countries, is as Jenna says, what's the carrot, what's the, as it were, excuse the expression here, what's the carrot, what's the stick here? And again, one of the things we have to think about is the extent to which organizations like the World Bank, in particular, make demands on countries that feel like they cannot answer back, and so it becomes the requirement that you accept this or else. And so that's, I think, one of the issues, again, this raises about the autonomy kinds of questions for countries as well as for individuals. But I don't want to be naive about saying, look, there's just an easy answer here and we shouldn't be doing this, and maybe it would be really helpful. I guess one of the questions we'd want to know is, where's it being tested? If it turns out to be really disastrous, how fast can we fix it? All those kinds, and who's going to pay for that? Those kinds of questions is what I would be asking.
We've been talking a lot about medical trials. I was wondering if there were equal ramifications for psychological testing after Nuremberg?
Yeah, definitely. Certainly, we know that in the wake of the Nuremberg trials, the American psychological community began to also explore these issues. And over the course, in the late 40s, I know there was a small group of psychologists who began to try to began this sort of process and procedure of working out a similar kind of code for psychological experiments. And this has continued since that time. The story of psychologists is a bit murkier. And in part, and the reason why, interestingly enough, one of the things the gentleman before was talking about Guantanamo Bay and the use of psychiatrists and medical people and psychologists there. One of the things that we're hearing of is as some medical people are trying to distance themselves from that work, they are trying to turn to psychologists to step in to do that work. And part of the historical reasons why I think psychologists may be, in fact, a little more receptive to that has to do with the long history of psychology, which is, I think, we today, when we think of psychologists, we think of people who talk to people, counsel people, try to help people. But in fact, the vast majority of psychologists historically have not been a part of the helping professions. They have been testers, they have been analysts, they have been individuals trying to find ways to conduct experiments to understand how to get people to work more prodigiously. These kinds of things have made them more receptive to application. And so what we have found, and what many historians and scholars have talked about, is the fact that there seems to be, in some sense, if you will, the doctors are a little farther ahead of the psychologists in the idea of trying to establish certain working ideals and working principles for conducting experiments. The most infamous study of all in this regard is the famous Milgram Experiment. It's one of the most famous, Stanley Milgram's obedience to authority experiments, where he tested subjects and gave them basically this false test where supposedly individuals who would stand behind some kind of glass door or whatever would be administered electric shock by an individual who was not in the know about this and who was supposed to teach them to remember certain kinds of signs and signals in the process. And in any event, the subject who was the subject in these experiments was supposed to press a button every time the individual on the other side of the glass window or door got the answer incorrect, supposedly administering electric shock to the person. The person wasn't in fact being shocked, but was an actor. But the experiment was all about to see the extent to which that individual who was pressing the button would do what the scientist and researcher wanted them to do. And this was in part a lesson that in and of itself that was seen as, well, in fact, the experiment itself derived from the Nazi period, or derived out of the Nazi experience, because, in fact, what Milgram was trying to prove was, in fact, that Americans wouldn't behave like Germans behaved. And he found just the opposite was the case.
Right.
But what's interesting is, while that experiment seemed to demonstrate some of the problems in the ways in which researchers and scientists are obeyed, many people have said, the real problem was Stanley Milgram.
Right.
The experiment itself is unethical in deceiving people about people having heart attacks on the other side of the glass. So it raises
sadism.
and an element of sadism.
Right. And in fact, it's the Milgram experiments and a whole series of these other kinds of things that starts to push the conversation in the mid-60s and into the 70s, of which Tuskegee then becomes the sort of big explosion over it, that pushes us toward the National Research Act and the institutionalization of institutional review boards. So an experiment like Milgram's would never presumably have passed an institutional review board's overseeing of it today, we would hope, although we know that some things obviously get through, but it did have that effect in being one of those big things that pushed. And it goes back to the question you asked earlier, which is that a number of these sort of horror stories have to kind of happen, these paradigmatic stories get used because we need the sort of, oh my God story, right, to push us to worry. And the problem with them, I think, sometimes, aside from the ways in which they get written in these very narrow ways is, so we don't know their complexity, but it's also that it's then, again, too easy to distance yourself. So you can say, oh my God, I'd never be Stanley Milgram, or I'd never be those guys in Tuskegee. And I think what we should be teaching are the sort of really easy, I think you're better off teaching the person who asked me to let my son go under the MRI longer than Tuskegee, because I think it's more normative. And as problematic in some, I mean, not as in horrific consequences, I mean, so clearly, but in terms of the allowing an ethos to develop that says this is just easy to do, I think is really is very, very dangerous.
Yeah, I think when you study these issues of not just medical ethic, but ethical dilemmas in the world, historically, is one of the things I think one senses and one comes away with is ethical dilemmas very rarely present somebody by knocking on the door and saying, hello, I'm an ethical dilemma, I'm here. It is creeping, it is mundane,
That's right.
It doesn't appear to be abnormal, it appears to be something that just is there.
It's banality of
It's
evil.
very
Banality of
banal,
evil, right.
and that in essence is I think what you're partly saying is don't be looking for Tuskegee or Nazi medical atrocities, but in fact the devil is in the details and in the mundane. But,
That's right.
Yeah.
That is such a wonderful concluding statement. I'm almost sorry to ask an additional question. I suppose, in fact, it follows directly on what all three of you have been saying, which is to be able to recognize a dilemma. And because, of course, science is a wonderful provider of authoritative knowledge, which other authorities, like political authorities, will easily use in order to render their authority unquestioned, as in the case of Guantanamo, for instance, where, of course, the United States administration has dealt with reports and protests from very authoritative bodies like the United Nations by saying, well, these are just, a rehash of old allegations. And remember, they are terrorists.
Right.
So there are ways in which science and the threat of attack are used to disable the idea that this is a question, that the authority is not unquestioned and simply as stated. And I think this idea that science has its own history is very important to bear in mind, because it helps us to recognize the existence of contemporary dilemmas. Because, of course, the same science that creates this unquestioned authority is the science that in the 19th century drew the line of the human, so that black people felt very much outside of that boundary. So it seems to me, from what you've been talking about with the Nazi doctor trials, that science helps to draw that boundary of the human. And that when we recognize that science has itself been implicated in where we need to question its authority and its findings, it helps us to recognize the dilemmas that we are undoubtedly facing today. And so I think this is a very important debate to track forward to where we are, where increasingly political authority would say, oh, there's no question, of course this is the right thing to do, but where we at least need to know that we need to question.
Yeah, a friend of mine writes, he quotes the old Tom Lear song, and I won't get it exactly right, but it's the Werner von Braun problem of, I just make the rockets go up and I'm not responsible for where they come down. And I think we have to think about how do we help educate people in science to break through new barriers, to be brave enough to do something. Frankly, as I said earlier, I'm probably alive because of some of those cowboys, so I'm not going to start into the cowboy metaphor, we'll really be in trouble, but especially these days. But I think so. We want, on the one hand, to encourage. We don't want to stop that from happening. I think what we want to do is to make sure that these kinds of discussions happen between the public and science people. That science people understand why people are afraid and why those fears are justified, and also think about what they're doing in a kind of really concerted way, and rethink that all the time. The thing is, it's not like providing there's no such thing as cookbook ethics. If you're a really good cook, the cookbook is kind of, the recipe is kind of a suggestion. Like tablespoon of salt, but what if you don't like, you want to use a little less. So it seems to me one of the things we want to do with scientists is say, we have to talk about this all the time. We have to think about where the barriers are, what's happening now. Maybe this, the men who did Tuskegee thought what they were doing wasn't wrong. And no one, very few, a couple of people around them tried to stop it, but most people thought it was perfectly okay to do that. And I think we need to have this ongoing conversation all the time back and forth between the groups, because we can't do it. I know it, all of us who do research know you get so involved in your own work, you lose sight, you get blinders, all of us do. And I think we have to acknowledge that that's a problem, and that's why you need outsiders to go, wait a minute, what the heck are you doing here?
And the idea of a reflective practice is really important. I think historical reflection is crucial. I mean, eugenics grew directly out of the race sciences of the 19th century, which in turn grew directly out of 19th century imperial policy, which needed a damn good reason for the expansionism and the absolute domination that their governments were undertaking. What better than the kinds of 19th century race sciences which said, actually, that kind of person needs to be dominated. You're doing the right thing. Right? From that, you get eugenics. And the idea that you can actually manipulate heredity and you can manipulate stock. But did those race scientists understand their complicity with government? No, it's never that obvious. This is our reading history against the grain stuff. This is the Benjaminian historical materialism. But let's keep doing that. I mean, let's keep asking, who's going to benefit from this, really? Who are all the beneficiaries of this? Not just our proposed patient population, but what kinds of structures are in place right now that are actually resisting a kind of completely reflective relation to what it is we're doing, or what's encouraging?
Yeah, and what I would add to this is a question that is often raised that comes up when you talk about these experiments that were conducted under the Nazis is a perfectly legitimate question to ask, which is, was there good science there? Was there anything useful that came out of it? And my former colleague from here, Robert Proctor, wrote a very interesting article in which he said we need to distinguish between medical integrity and medical ethics. And that, in fact, strangely enough, in many ways, the Nazi scientists, the German scientists during the Nazi period, had a great deal of integrity in the sense that they didn't taint their research, didn't lie about it or anything like this. But what they lacked was a kind of a sense of medical ethics. I view it a little differently, and I won't get into the integrity thing, but the way my spin on that is the way the Nazi doctors, or the doctors, I like to better put it, called German physicians during the Nazi period. It's important to say that. The way they failed and how they failed is not as scientists. They failed as human beings. Right. They lost sight of the greater good. They lost sight of what it means to be a human being. And that is because they bought into much broader issues, much broader definitions of what it means to be human, a citizen, a person. And in that sense, this story, as I guess I've been trying to say, is not just simply about medical ethics. It's about what it means to be human in a modern society. I think we're about to wind down, and so this is our opportunity to have some final closing comments if you'd like them. I always think of as an historian, I always think of what a colleague of mine said should be the motto for all historians, which is historians solving yesterday's problems today. We are very good at post-diction, not very good at prediction. Right. So I'm not going to offer any prognostics today, but I will leave it to you two if you have any final comments or anything you'd like to say. And if you don't, that's fine too.
I would, and this was my actual final note to myself when I was coming over tonight, keep your eye on the fate of the mentally disabled, because it will tell you a lot about what's going on in that culture, what the cultural values are, whether they're shifting, and it will tell you a lot about what kind of solid ground or shifting sands you have for an ethical culture.
Mm. And I would pick up on what Greg says. I don't think you can practice what one historian called preventive history. But I think you can learn from it. And I do think you can look at what's happened before in these big cases and in the very small and mundane ones and remind yourself that those people are not so much different than we are. And I think if we keep that in mind, if we don't speak the way the Tuskegee physician did, who said, but they were Nazis, then we won't have learned anything. So I hope that you will not take into your heart that you're a Nazi, but that you will take into your heart that it could happen to any of us on either side of the story, and that we need to be cognizant and keep that conversation going.
Well, I want to thank my fellow panelists, I want to thank WPSU, and I want to thank all of you. I, for one, learned a lot, so thank you very much.
Thank you.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.